Good afternoon, everybody. I'm Don Pai. I am co-chair of the International Advisory Board of CASI. I'm also a university trustee, a advisor on the Board of Advisors for School of Arts and Sciences, and I'm also the chairman of Penn Medicine. And as you can tell, with those multiple affiliations, I'm actually very proud here today because today's program is actually a confluence of two of my passions here at Penn, both in arts and sciences and in Penn Medicine. And today's conference is thanks to our fearless leader, Tarek. It shows the collaborations that he has done across campus in forming a partnership, not just having this event sponsored by the Center for Advanced Studies of India, but also by the Center for Global Health and the Perelman School of Medicine. So now, with that, I'm going to get out of here because there's much more smarter people that you want to listen to. But let me introduce our leader, Tarek Tachil. He's the professor of political science here at the University of Pennsylvania. He's also the Madan Lal Sobti Professor for the Study of Contemporary India and Director for the Center for Advanced Studies of India. It's yours.
Thank you, Dhan, and thank you everyone for being here. As Dhan mentioned, my name is Tarek Tachil, and I'm Director of the Center for Advanced Study of India, CASI, and I welcome you to today's Khemka Distinguished Lecture by Dr. Gagandeep Kang. Let me begin by thanking the Nandanjeet Khemka Foundation, whose generous support makes these series of public lectures possible. Let me also thank the Center for Global Health, which has partnered with us for this event, including Glenn Galton, Megan Doherty, and Matthew Deach. Last but never least, thanks to my fantastic colleagues at CASI, Juliana, Georgette, Junie, Alan, Rachel, Nikhil, Shahana, Matt, Kiran, Jitender, Manya, and more, for everything that they have done to help organize this visit and Dr. Kang's time on campus and everything that they do. Our speaker, Dr. Gagandeep Kang, is a distinguished physician scientist who currently serves as director of 3 strategic areas at the Gates Foundation: enteric and diarrheal diseases, diagnostics, and genomics, epidemiology, and modeling. It is my pleasure to welcome her to CASI and Penn, where she's already been very generous with her time. She had an informal and lively lunch with students from across several schools a few hours ago. Tomorrow she'll record an interview with us in the morning and then join the Center for Global Health for a discussion between 12 and 1:30. For those interested, it's in the Biomedical Research Building's 14th floor. And we thank her for engaging with so many of us on campus. Dr. Kang moved here to her current role at Gates after a long and distinguished research career as professor in the Division of Gastrointestinal Sciences at the Christian Medical College, CMC, in Vellore, which was established in the year 1900 in the state of Tamil Nadu, India. She's a member of several advisory committees for national and international institutions, including the World Health Organization, International Vaccine Institute, and others. She's the winner of many accolades, including becoming the first woman working in India to be elected a Fellow of the Royal Society, the famed FRS. She is also the first Indian woman to be elected to Fellowship of the American Academy of Microbiology and received India's prestigious Infosys Award in Life Sciences. Most recently, she was awarded Canada's 2024 Gardner Global Health Award. Her research has been as wide-ranging as it's been impactful. At CMC, she was driven by a desire to, quote, take the best of what global science has to offer and then adapt it to suit underprivileged populations in India, who were, in her reckoning, often left behind regarding medical innovation. That drew her to focus on pervasive problems like diarrhea that remained under-researched despite continuing to claim the lives of nearly 1 in 12 children below the age of 5 in low to middle income countries. Her research group has established substantial community-based birth cohort studies that generated extensive information on the complex interactions between the environment and infections in children and the influence of prior infections on subsequent responses to vaccination. Among other things, they conducted the single largest birth cohort study on rotaviral infections in the world, demonstrating that protection after a natural infection is lower in India than in wealthier nations, which has important implications for the control of diseases by vaccination. She has also conducted key studies contributing to the development and introduction of 2 Indian rotavirus vaccines in the National Immunization Program. And most recently, she became a leading national voice, and I'm sure familiar to many of you across the world and in India, on the COVID-19 pandemic, both in understanding the disease, in thinking about appropriate policy responses and informing the public through her interviews and writing, including a shameless plug, Cassie webinar that was conducted during the height of India's deadly second wave in May 2021. She's the co-author of a best-selling book, Till We Win, India's Fight Against the COVID-19 Pandemic. In today's talk, we invited Dr. Kang to reflect on themes close to her work and interests. Most of her globally recognized insights, including many that I just listed, came from a research program that she built and centered in India and prioritized the contextually specific needs of Indians, while also providing insights that are translatable and valuable for other regions and settings. So we asked her to talk to us about how her career, which has been so firmly embedded in India, will inform her new role at Gates in her talk, Building Global Health Research from India for the World. And then after her talk, we are delighted to have a distinguished panel of colleagues from the Perelman School of Medicine join Dr. Kang in a conversation followed by an audience Q&A. I'll just introduce them now, and you'll see them afterwards. Glenn Galton, who is the Perelman School of Medicine Vice Dean and Director, Center for Global Health, and Professor of Pathology and Laboratory Medicine. Dr. Surbhi Grover, who is an Associate Professor of Radiation Oncology, Director of Global Radiation Oncology here at Penn, and an Adjunct Senior Lecturer at the University of Botswana. And Dr. Sarah Cherry, who is the John W. Ekman Professor of Medical Science in the Department of Pathology and Laboratory Medicine. Following the Q&A, please join us for a reception with food and drink in the Sphinx Gallery. Thank you for bearing with me, and please join me in welcoming our 2024 Cassie Khemka Distinguished Annual Lecture Speaker, Dr. Gagandeep Kang. Thank you.
Thank you. Introductions are always a bit overwhelming. But thanks, Tariq. I've had a really good day with students here, and I'm looking forward to interacting with you over the course of the evening. So to start with, lots of good things get said about speakers, but speakers are nothing without the teams that they work with. And this is some of my team who turned out on a Sunday morning because we were having some visitors and they wanted to meet people, and this was the only time that was possible. Somehow I get the feeling that no matter how productive your research team in the US, this would never happen. So I'm going to be talking to you about my education and how unusual it was, and then talk to you about enteric infections, highlighting a few key things that Indian researchers have done and what they really mean for the world. In terms of building for the future, I hope as I walk you through this, you will see the problems I've encountered and then be able to equally answer the approaches that I've thought about taking at the Gates Foundation. So if we look at medicine, medicine has been taught in much the same way for the last couple of thousand years. You have a really good teacher, the teacher has disciples, the disciples learn from the information and the training that the teacher provides. Now this is a very Western system of medicine. Not that Indian systems are very different from this, but Western medical education functions like this. And in thinking about the kinds of problems that are encountered in places like India, a lot of people in South Asia in the 1970s began to think about whether this was really appropriate. The textbooks were Western textbooks that were taught in our classes. The problems that we encountered frequently were not problems that had been seen to the same extent in the Western world. I'll give you an example. All of our leprosy teaching, and leprosy was a big problem in India in the 70s, 80s. All our leprosy teaching came from work that had been done by Norwegian scientists that had moved to tropical countries, done research there, gone back, and then written about the work that they had done. Similarly, if you look at the drugs that we use, the drugs, everybody knows this, are intended for people that may have a somewhat different physiology, a different genetic predisposition than South Asians necessarily have. So the WHO convened a number of countries, and Thailand and India were key leaders in this, to think about what does the trainee doctor really need to encounter during their training so that they can serve the populations for whom they are working. And what they came up with was the fact that most doctors come from urban areas, have never encountered the kinds of lives that people live in rural areas, and frequently, because of their teaching, are not necessarily set up to be able to address common problems. So in a big hospital, you get tertiary care medicine. You very rarely get primary care medicine. And yet, if you think about the needs of the population, you need to start from primary care. So this approach which was recommended by the WHO, was called the Reorientation of Medical Education, or the ROAM program. And my institution, the Christian Medical College, Vellore, took this up in 1978. Currently, there are still 2 institutions in the country that follow this approach. And the 2 are CMC Vellore and the Mahatma Gandhi Institute of Medical Sciences in Wardha, or Sevagram, where Gandhi lived for 12 years. And in CMC, there were 3 models of community care that were set up. Each of these was intended to be for an administrative block, which is a population of 100,000 people. And in CMC, the most intensive model is the one that is on the left. And that is, you start with every village having a part-time community health worker. When you started with reproductive and child health, the idea was identify every pregnant woman and get her to come for an antenatal visit at least 4 times during her pregnancy. Make sure that when she gives birth, it is in the presence of a trained birth attendant instead of the traditional midwife. The second level was take that primary care worker, the part-time community health worker, have her supervised by somebody who has some level of education, usually a high school graduate. And this person was called a health aide and was responsible for 5 part-time community health workers. So you go from 1,000 people to 5,000 people. Then you go from 5,000 people to about 30,000 people, where you have a community health nurse who supervises half a dozen health aides. And then the community health nurses, 3 of them are supervised by a doctor. So you're getting information on 100,000 people, but it's feeding up to only 1 doctor. Now, that's not what WHO recommends, but it is a tiered model of primary care. In the second model, we decided that the focus was going to be not only on medical care for the population, but also thinking about social affairs. What does it mean for people to have economic empowerment? So there was agriculture, animal husbandry, technical training. And here we relied on a community health volunteer and a social worker and a program coordinator for that. So much fewer tiers, much less information flowing through the system. And the third model was leave the government to do what the government is doing when the primary health care center requires some support, provide that. Mostly it was in the absence of staff, or occasionally if they wanted technical support. So when I joined medical college, these were the 3 models that were available. And through our training, we got exposure to all of them. So I spoke about part-time community health workers, and our very first part-time community health worker is shown here. She was a dai, or a trained birth attendant. So what was done with all of the dais was to bring them in and train them in simple things like not putting cow dung on the umbilical cord, making sure that you had a clean, new blade to cut the cord each time, knowing when to refer women who were wanting to give birth in a hospital. How was a high-risk pregnancy to be identified? So that was the system that was built. That there is our 80-bed hospital using the architecture that people were familiar with, the same tiled roofs that they had in their houses. The economic training programs, training women into things that they would not ordinarily do, like being motor mechanics and having a welding shop. And then we had what were, anybody remember the emergency in India? Okay. So after the emergency, there was a health minister, Raj Narayan. Raj Narayan decided every medical college had to have a mobile clinic. These were called the white elephants because they were so big that they couldn't get to remote villages. We still used them wherever we could, but you had to have a road that was big enough to be able to accommodate these. So great principle, but in practice, there tends to be a gap between what people in Delhi decide and what needs to be done at the village level. So as medical students, you get sent out to spend 3 weeks in the village in your first year, and you learn how to collect information, how to do focus groups, how to see babies and mothers under a tree, and that teaches you a lot. It teaches you about people's lives. It tells you about ownership. It tells you about divisions in a village society, who has what kind of power. And power in India, we know, isn't money alone. It is very much your social standing. So that kind of exposure of really learning from the community informs everything that students from my institution do subsequently. So now I'd like to come to what we learn through these approaches. Now what this is, just to set it up, is 4 different measurements of burden. So if you look up here, this one is looking at all children under the age of 5, shown here. And this is a figure from 1990 showing what did children under the age of 5 die of in 1990. I'm going to show you 2 figures. LRI is lower respiratory infections, and diarrhea is here. Okay? Now we come to the same thing in 2021. You see that the LRI has shrunk, the diarrhea has shrunk. This is the global picture in 2021. Neonatal causes are a much greater cause of deaths than respiratory infections and diarrhea, global causes. Now we are looking at 2021, and what we are doing is looking in an area that is low socio-demographic index. So poor countries in 2021, what do we see for LRI and diarrhea? So if you think about it, in America, do you expect children to die of respiratory infections and diarrhea? They shouldn't, right? They'll get care. So this is the picture of high-income countries. These are LRIs, this is diarrhea. So a few children die, but it is a minor cause of death in children. Instead, you have a lot more congenital anomalies, and you have a lot more problems that happen during birth. The absolute number is smaller, but even in that absolute number, respiratory infections and diarrhea are not contributing. If you look at poor countries, respiratory infections and diarrhea continue to be a major cause of children under 5 dying. So I started to work on the gut, and I loved the gut because, tell me, anybody in this room who's never had a diarrhea? Nobody? How surprising. Okay, because it's absolutely fascinating. It's inside the body, but it's outside the body. It's not a completely sterile environment. When you see a bug there, is that really causing disease or not? You don't know. And you have to figure out, how do I solve a problem where I am not even clear exactly what the problem is? If I find 2 bugs, how do I know which one caused the infection or caused illness, right? So the gut also has multiple functions. It's responsible for absorbing food. If your gut is not working well, you have poor absorption. It has an immune function. So lots of things need to work for your gut to remain healthy. But if you live in poor environments, that can be quite challenging to do. So this is an example of the community in which I worked, which is an urban slum area. So lots of open drains. You can have mud flooring. Your kitchen might need to be outside the house. Water is not necessarily safe. So it's unsurprising that there is a lot of diarrhea. But if you look at what causes that diarrhea, how often do we know? So in the US, of all of you who have had diarrhea, how many of you knew the cause every single time? The only way you find out what is causing the diarrhea is when you do really detailed studies. And there have been a lot of studies done around the world. I'm not going to walk you through this, but just to show that in a 7-country study, in children less than 1 year of age, rotavirus was the #1 cause of diarrhea, and then you had other pathogens. And if you use different methods, you wind up with different rank orders for a variety of pathogens, but not for rotavirus. It was #1, no matter what kind of method was used. Now, rotavirus causes acute watery diarrhea. There are many pathogens that cause acute watery diarrhea, but the one that everybody knows really well is cholera. What's your picture of cholera? People who get very sick very quickly and lose a lot of fluid, so much so that the stool that you produce in cholera is called rice water stool. It is so thin and there is so much of it. Now, the fact that cholera is caused by a bacterium was known for a long time. Robert Koch was the person who identified the cause of Asiatic cholera, as it was called, in the 19th century. But Koch didn't know how it worked because these bugs didn't get inside the intestine, unlike many others. So it was really Shambhunath Dey, working in Calcutta, who figured out for the first time that this was a bacterium that produced a toxin that was secreted. So the bacteria was putting out something. That something was resulting in signaling mechanisms that resulted in the intestine leaking fluid and leaking buckets of fluid. Now, lots of people tried to figure out how to treat cholera, and it was really hard. Then people figured out that, the problem of cholera is you're losing fluid, we need to replace the fluid, and IV rehydration came in as a solution. And IV rehydration saved lots of lives when there were outbreaks. But IV rehydration in a dehydrated person is really hard. When you become dehydrated, you're losing so much fluid that starting an IV line becomes hard. And if you don't have skilled people, starting an IV can be challenging. And think about doing that in children, it becomes even harder. So people die because they don't have access to care. So there were some discoveries These discovery, obviously, of an enterotoxin in cholera was very important. But in the subsequent 2 decades, there were a number of studies that were done that looked at why, what could be done to make fluid repletion easier. The key findings really were that if you wanted to rehydrate someone orally, you had a mechanism where absorption and secretion were actually separate functions. So if you gave sugar and salt together, you could use a transport mechanism across the gut in order to be able, so just giving saline wasn't good enough. You had to add sugar to the solution so that a glucose-sodium transporter could work and allow for absorption of fluid. Now, this work was the work of a lot of different people, a lot of them who were working at what is now ICDDRB in Dhaka, as well as in Calcutta at the Cholera Research Center. But it was scientist Dilip Mahalanobis who, during the 1971 war, found that he was unable to give IVs to all the people with cholera during the outbreak there, and actually tried out oral rehydration solution. So the work had been done in small clinical studies. He showed that this was something that was effective at scale and wound up then saving millions of lives. Now, that is acute damage, an enterotoxin causing acute damage. But you also, when you have a lot of infections, you can get infections that persist for a long time or happen repeatedly, and that can result in chronic damage. The only thing I want you to look at here is this picture of environmental enteropathy. If this is a healthy gut, children who have repeated exposure to bugs wind up with a gut that looks like this. So the gut is usually finger-like villi, which you can see quite clearly. And then if your finger-like villi become folded up like this, you lose the villus structure, you wind up with an inability to absorb. And that's fluid, nutrients. This happens to kids very early in life and then persists through life. Now, in addition to that damage that happens to the gut architecture, when you have multiple pathogens, you also get a lot of inflammation in the gut. So this is a picture of studies that I had done in Vellore, where I was intrigued by this question of how much of a difference does your environment make? Now, you have lots of studies that compare kids in rich and poor countries, but there are never studies that compare rich and poor in the same country. So this study is children from Vellore who live in slums and doctors' children. What you can see here is that children in slums have 4 times the number of bugs in their gut as doctors' children. They also have much higher levels of inflammation. So it's not surprising that their guts are damaged. And this is a growth chart showing what happens to a child that has repeated infections. Have you seen a road to health chart where the doctor plots how your child is growing? They take the height, the weight, and they tell you your baby is doing well or not doing well. Well, this is normal, and this child, every time they get an infection, gets knocked off that road to health and then continues to grow more slowly than they should be growing. And this is what happens when you have gut damage. So over a period of 20 years, this is work that we've done. So as you can see, this child looks normal, doesn't he? Looks healthy. He's stunted, which means he should have been 104 centimeters tall. He's only 97 centimeters at his age. So he's lost 7 centimeters in height, whereas this child is appropriate for age. So what happens to kids who live in urban slums when they live there? A third of them are stunted. The stunting is bad enough, because they don't grow, but kids that don't grow physically in height also have smaller brains. We've now done MRI studies to show that the white matter in brains of children who have stunting is thinner than in children who are not stunted. If you measure their IQ, normal IQ should be about 100. These kids have lost 10 IQ points just by living in the slum. And among them, the ones who are persistently stunted over a decade or more are significantly lower IQs than even that 89. They tend to be around 82. So this is the kind of damage that you get when you live in these environments. And we've done diet histories in these kids. And it's very clear that they don't have calorie deficiencies, but they do have other kinds of deficiencies that lead to them not having the kind of physical or brain development that they should have. Now, this is something that we started working on in India. There was work that was happening in South America at the same time, and more recent studies have shown that this is a feature of infections in Africa as well, unsurprisingly. And so now when we are thinking about interventions and when interventions need to happen, we actually have a global picture of when we should start to address damage. And the answer is obviously as early as possible. And early as possible means actually starting with their mothers so that they can be looked after well. This is the approach that we are taking at the Gates Foundation, where we are looking at growth and resilience, making sure that kids don't get knocked off the track that they should have for normal growth. What is it that we need to address in pregnancy? What do we address in the perinatal period? What do we address in infancy? And each of these requires comprehensive solutions. Now, chronic gut damage has other consequences as well. Oral polio vaccines. We still, unfortunately, have polio in the world, and some of you might remember that in countries like India, we had something called National Immunization Days, which were around giving oral polio vaccine to all children under 5 twice a year, even if they had received vaccines during their immunization schedule. Why was that? That was because in the West, you have very effective vaccines. So if you look at polioviruses 1, 2, and 3, after you've received 3 doses of vaccine, you have practically 100% protection against all 3 poliovirus types if you're in the US. In developing countries, not so much. Poliovirus type 2, reasonable, but 1 and 3, you get about 70% protection after 3 doses, which actually means that if you look at figures from UP, each dose is giving you an additive 13% per dose, which means kids need many more doses of vaccine for us to get there. So polio is a problem that has been with us for a long time. And in India, this is a map from 2010 showing cases of wild polio virus. And in 2011, we had the last case in India, which was in a girl who was unimmunized, Rukhsar Khatun in Howrah. Now look at what it took for us to get to 2011. This is the map of national and subnational immunization days. These are the number of vaccines our children were getting for us to be able to get to a point where we had the last case of immunization. So 3 doses in the US and these many doses in India. Well, the gut is responsible for a lot of things. Now, many of these studies were actually done in Vellore by my mentor, Professor Jacob John. So he did studies in the late 1980s in Vellore that showed that if you used OPV, the efficacy of OPV was about 66%. if you used IPV, the injectable polio vaccine, instead of the oral polio vaccine, efficacy was 92%. Now, does it make sense, based on these data, for the country to switch to IPV? Well, the Globe decided in 2016, which is about a quarter of a century after these studies were done, that the switch to IPV had to happen. And even then, it wound up being a partial switch, and we are still dealing with the consequences right now of too much use of OPV, because OPV is a vaccine that can revert to neurovirulence. So even though Afghanistan and Pakistan are the only countries with wild poliovirus now, in Africa, we actually have a lot of circulating polioviruses that have come from the oral polio vaccine. And that's a new problem that we now need to solve for. And the answers were actually available to us from 25 years ago. So we need to think about, when data from developing countries gets disregarded, the consequences that it might potentially have for the world. So oral polio vaccines are one among the many oral vaccines that all perform badly in lower income settings. Nonetheless, when you have oral vaccines, what does the lower efficacy mean? And this is my one science slide that I'm going to take a minute over to explain to you. So I don't know if you can see behind the flowers, but I will read it to you. So this is a rotavirus vaccine that was tested in Bangladesh and in Vietnam. Which is the richer country of the two? Vietnam. So in Vietnam, the vaccine had 72% vaccine efficacy. In Bangladesh, the vaccine had 46% efficacy. That's as expected. Rich countries, oral vaccines do well. Poor countries, oral vaccines do badly, right? So we shouldn't use oral vaccines in poor countries, right? Not right. And why? Because if you look at the background of disease, if you took 100 kids and you followed them for 1 year and looked to see how many kids got severe rotavirus gastroenteritis, in Bangladesh, 9 out of 100 kids would get severe rotavirus gastroenteritis in 12 months. In Vietnam, that was 3 children out of 100 would get severe rotavirus gastroenteritis in 1 year. So if you look at 46% efficacy, what does that mean? It means that about half of the 9 episodes are prevented. So at least 4 episodes of severe rotavirus gastroenteritis are prevented in Bangladesh with a vaccine that doesn't work as well. But in Vietnam, only 2 episodes get prevented from a vaccine that works better because your background disease is lower. So where you have more disease, even if your intervention is less effective, your ultimate impact is higher. So you should use oral vaccines even though the vaccine efficacy itself might be lower. The other slide shows the same thing for a different vaccine in the same sort of comparison between Malawi and South Africa. So I've shown you in the previous bar diagram that you saw, rotavirus is a common cause of gastroenteritis in young children. And children are, they dehydrate very quickly. They have a large surface area for their body size, which means if they lose fluid, they become dehydrated quickly. So rotavirus is called a democratic virus, and that's why you have rotavirus vaccines in the US, because kids here get it too. And if you look at diarrheal deaths in the world where rotavirus, when vaccines were first introduced in the US, the vaccine was first introduced in the United States of America. Where do you think the problem was? Okay, That vaccine was withdrawn. 2 new vaccines were introduced after a lot of testing. And those vaccines, when they were introduced into the US in 2006 and 2008, actually cost $200 for a course of vaccines. It's gone up a little bit now. I believe it's between $210 and $240 to now immunize a child in the US. So these vaccines were incredibly efficacious, and in India, we knew we had a problem with rotavirus because we had been doing studies looking at severe rotavirus gastroenteritis. Now, when we looked at disease burden, at that time, 1 in 650 children born in India was dying of a rotavirus gastroenteritis, about 80,000 deaths that were occurring every year. These are figures for 2011. So it was clear that we needed a vaccine, but we couldn't afford $200 to immunize our birth cohort of about 25 million children. So there was an Indo-US vaccine action plan that had been looking at rotavirus vaccine development. The work on this was done by Professor M.K. Bhan, who was a pediatrician at All India Institute of Medical Sciences, subsequently became secretary of the Department of Biotechnology. So this strain that he had identified was unusual. He took it forward in partnership with the US, particularly the NIH, and with Stanford. And this vaccine wound up getting licensed to a brand new company called Bharat Biotech. They repeated the studies that had been done in the US, but by the time the vaccine was ready for field efficacy studies, the multinational vaccines from Merck and GSK had already been licensed in India. So then came the problem of, can you do a placebo-controlled trial? So there was a consultation with WHO that said that under certain conditions, we could go ahead and evaluate this vaccine in a placebo-controlled study because it was important to demonstrate efficacy in India before we used the vaccine. So we did this study. It was a really intensive study. It was actually the first phase 3 study of any vaccine that had been done in India with a clinical efficacy outcome. We did this study. We found that it had an efficacy of 55%, which was in line with the efficacy that had been seen with multinational vaccines in Africa and Bangladesh. This was licensed by the Indian regulatory authorities in 2014, and it was priced at $1 a dose. So $3 to immunize a child fully, as opposed to the $200 in the US. Why only 55% efficacy? Well, this is a lifetime's work. I'm not going to explain it all to you, but just to say that based on our studies of natural infection, we had actually predicted it would have about 50% efficacy against diarrhea. So 55 was not bad. So in March of 2016, the vaccine was introduced. By 2019, all of India was using the rotavirus vaccines that were made in India, first starting with the Bharat Biotech vaccine, but also using a second Indian rotavirus vaccine that was developed in collaboration with the NIH, made by the Serum Institute of India. And this was a vaccine that was evaluated both in India and in Africa at the same time. Now, to cut a long story short, I'm very happy to say in 2023, among the poorest countries in the world, 3/4 of the world's needs are being met by the 2 Indian vaccines. So first phase 3 studies in India resulted in products that have been qualified by WHO and that are now truly serving global needs. Now, I'd like to point out one other thing to you. So can you see that there are solid colors and dotted lines in the same solid lines and dotted lines? Okay. Let's walk through each of these. In orange, solid line is rich countries. Dotted line is poor countries. The Gavi Alliance buys and introduces vaccines into poorer countries, Gavi-eligible countries. Can you see that the orange line overtakes? So they start much later, and that's a feature of all vaccines. All vaccines go first to rich countries, and then they come to poor countries. What Gavi does is try to shorten the gap. But what Gavi is also doing is making sure that coverage in those countries is higher than coverage in rich countries. So really promoting immunization in the poorest countries in the world. Can you see the blue line? Blue line, again, starts much later and then goes up, is higher. That's rotavirus, and this part all driven by Indian vaccine manufacturers. Can you see the green lines? They haven't crossed yet. Why? Because these vaccines are not yet being provided by a developing country vaccine manufacturer. Pneumococcal and rotavirus vaccines are. So once HPV comes in, we hope that, again, the lines will cross and kids in poor countries will be well protected against a virus that causes cancer. So India's place in the world of vaccines before COVID-19 was really pretty good. We were providing 40% of the global vaccines by doses, but we were doing the cheap vaccines, the knockoff vaccines, the generics of vaccines. So what happened with COVID-19? Well, India imported no vaccines. India was the only country to have supported the making of vaccines on all platforms. We have an mRNA vaccine. It just came later than everybody else's mRNA vaccine. We have the only DNA vaccine. India managed to give out 2.2 billion doses of vaccine. And most of that vaccine is up here. This is Covishield and Covaxin. The first two vaccines that left the starting gate were the ones that had the greatest coverage. So which were the companies that made these two vaccines? Guess what? It was Serum Institute of India and Bharat Biotech, both the companies that had gotten the experience of making the rotavirus vaccines from scratch. So they decided that, having done this large-scale studies, they could go even bigger, go even bolder, and that's where they wound up. So they, Covishield obviously is also the AstraZeneca vaccine, so there were doses that were provided in India, as well as early and late provided outside of India. So this is what I've walked you through, how my medical education wound up getting me to work on diarrhea and key issues in diarrhea that have related to research in India, whether that is ORS or the story of polio vaccination or the making of rotavirus vaccines. So what do you think I'm going to do next? Well, obviously, rotavirus vaccines don't work as well as they should. So my question is, how do we make a better rotavirus vaccine? How do we solve for the problems that poor nutrition results in? These are the kinds of questions that I'm working on now with the foundation. And remember, I showed you those little triangles of the different models of care. So it makes me really, really happy that this is where the Indian government has landed with the new public health standards, which is around start with the village, look at what kind of care people need at the first level, what referral systems and what support needs to be provided through multiple levels of care. Not only that, earlier we looked at a triangle that was just reproductive, maternal, and child health. Now we are thinking about what care needs to be provided in primary care for non-communicable diseases, as well as through referral systems. So this makes it such an opportunity to be working in public health in India. And that's the engagement that I hope to continue to have. Just to leave you with, how much the world is changing. I showed you the depressing maps earlier, or depressing block diagrams earlier. But this is where we were in 1990 with diarrheal disease deaths. This is where we are in 2019. And as you can see, the world has gotten better. So I'm hoping that this is a trajectory that we can sustain and hopefully accelerate progress as well. I didn't have time to talk drugs, but India has brought vaccines and drugs to the world. So my question really is, now that we are stepping up in the world, what will we do next? So thank you very much for your attention, and I'll leave you with it.
Well, that was a fascinating and stimulating talk. And we have very comfortable chairs to sit in, I can see. Very nice. So I'm Glenn Galton, as was mentioned earlier, director of the Center for Global Health at Penn Medicine. And to my right is Sarah Cherry, again mentioned, but professor in, actually same department as I'm in, pathology and lab medicine, but she's really it's a bit of an atypical fit for our department because she's fundamentally a virologist and a microbiologist. And next to Sarah is Surbhi Grover, who's a radiation oncologist. And so we're going to talk among the four of us about a little bit of a panel discussion, and then we'll open things up to all of you to ask questions. So my first question is for you, Cherry, which is the rates of vaccine acceptance and the penetration of vaccines in India are in general, higher than in the United States, even though we often have, wonderful access to vaccines. How much of, and I think we all know there's a component of the US society that, sort of anti-vaxxers, as they're called. How much of the success in India do you think for vaccination rates and the acceptance of vaccines generally is attributed to this village-based, primary sort of a community-based care strategy? Or is there something else going on that maybe the US can learn from with regard to at least vaccinations?
Well, two things. One is we haven't forgotten vaccine preventable diseases because we've had them in the recent past, and especially diseases like polio that leave sequelae. Everybody knows somebody who has polio, right? So vaccine acceptance tends to be higher. And the second thing is, like in the US, everywhere else, who tells you about vaccines and do you trust them? If the information is coming from people that you trust, then the likelihood is that you will take the vaccines. If your message is against vaccines and it's coming from someone whom you trust, you won't take the vaccines.
Yeah, well, obviously we don't always trust the people in our government, but no comments beyond that because this is the wrong setting. But I want to follow up with that because again, we're all still suffering from post-traumatic stress syndrome post-COVID. So one of the vaccines that you mentioned, which was just as you said, produced in India, the Covaxin vaccine for the uninitiated scientifically. Obviously, most of the vaccines that we get, and we've all experienced this in the last month or so, an enormous push to get vaccinated this year. These are mRNA vaccines, which are vaccines against small components of only one part of the virus, the outer part, the spike. Whereas Covaxin is really a whole virus, inactivated vaccine. And there's been some discussion that maybe we should be getting not just only mRNA vaccines. So what's your thoughts on diversifying the dissemination of vaccines in places like the US, Western Europe, which have obsessed with the mRNA vaccines? And I say that, of course, recognizing, as you all probably know, the platform technologies for that were developed at Penn Medicine, and the Nobel Prizes won by two of our faculty. But nonetheless.
Yeah, so I think COVID vaccines gave us an opportunity to study what the advantages are of vaccines that are on different platforms. and what that means for the immune system. So it seems like, and the UK was a leader in doing the kinds of studies that immunize people with different platforms. The problem was you could only look at immunogenicity outcomes. And there it seemed like if you gave combinations of vaccines, you could wind up with a result that was better than having a vaccine that was on the same platform. mRNA vaccines give you a sharp rise and a sharp fall, whereas some of the other vaccines give you much longer durations of immune responses. So this is an opportunity for experimentation that we shouldn't pass up.
Yeah, we were talking about this a little before Cherry's talk. The need, as we've been experiencing, for I want to say constant vaccination and boosting, but at least annual. And the question is the expense associated with that, as contrasted to, are we better off? And of course, many parts of the world just can't afford that at all, and/or don't have access. But the benefits potentially of having vaccines that are directed to other more stable components of the virus, obviate to some level those costs, which is important. So I mentioned that Sarah is a virologist and microbiologist, and I don't want you to scare everybody, but most of the public was surprised by the emergence of COVID. The viruses in that category have come around in a fairly lethal fashion on a couple of other occasions over the last couple of decades. But maybe you could talk a little more, Sarah, about other potentially emerging pathogens and how we should be thinking about them, and particularly on the virus front.
Yeah, thank you. So my lab has historically worked on emerging viruses, and many of the viruses that we've been working on are mosquito-borne, right? So dengue virus is all over the world, and this has been a particularly bad year for dengue, and unfortunately, many of the vaccine platforms have been imperfect because of the different circulating strains of dengue. And so we have a lot of concern about these arthropod-borne viruses. Like I said, they're continuing to emerge and reemerge. I mean, we all heard about Tony Fauci getting West Nile virus like a few hundred miles from here, right? So historically in rich countries, we don't always think about these viruses, but they're even here now. And in India, they're a real problem, especially dengue and chikungunya virus, and we need to figure out how to deal with that. But to many of us, it wasn't surprising that the big pandemic was a respiratory virus, because it's harder to control interactions between people than it is on some level to control mosquito interactions. And so I think many of us continue to be concerned about respiratory pathogens as a pandemic potential. And many of you know about the high-path avian influenza that's going around all over the world now. And so I think it's really important for us to keep in mind that these viruses can come from different places, but we need to have mitigation strategies like these rapid platforms for vaccines, potentially new therapeutics ahead of the game, so that potentially we can stop a pandemic before it spreads.
Yeah, unfortunately, viruses have helped us understand, not that we didn't know it anyway, that the world is very interconnected, now maybe more than ever before because of the movement of individuals around the world. So, someone getting infected in China can move very quickly to the US or other parts of the world, and so viruses will spread, particularly the respiratory ones, much more quickly. But there's a lot of focus on vaccines, but what about other therapeutics to treat
Right, so
microbiological induced diseases, but particularly vaccine?
Right, so the first drug that was implemented against COVID-19 was a drug called remdesivir. And that was a drug that actually was first discovered many years ago, actually.
Wait, what about bleach?
Yes, that's also a very specific therapeutic. But remdesivir is a really interesting example because it was first developed for a different class of viruses. And then it was tested actually in the large Ebola outbreak in Africa. It was compared side by side against these monoclonal antibodies, and it didn't actually do better, but it didn't do poorly, but it also showed a good safety profile. And so it was known that these coronaviruses were susceptible to remdesivir, and so that was rolled out very quickly. The problem, or the one issue with remdesivir is that it had to be given IV. And so you couldn't give it to people who are just getting sick, and so it didn't show that much efficacy in populations because it was given a little bit too late. But it's an example of this idea of repurposing, that if you can find a drug that is active against large classes of pathogens, when a new virus jumps out, you might be able to implement it more rapidly. And so there's lots of efforts to find drugs that have broad-acting activity that can show good safety ahead of time and then potentially be able to implement it. And there's a large push to find these orally active antivirals.
Cherry, how effective in, say, I would say less well-developed settings and countries are therapeutics as contrast? I mean, obviously vaccines can be incredibly effective, but is it worth pursuing aggressively the therapeutics as well in more rural kinds of settings, or are the barriers to administering drugs and the costs of doing that prohibitive in those cases, do you think?
Well, you have to recognize that there are multiple systems of medicine and informal practitioners in India. So while antivirals were widely available during COVID, but have not been widely available at other times, antibiotics are very easily available and tend to be misused quite a lot. Yeah. So therapeutics, given that drugs in general are cheap in India, is delivering them is not a problem. Delivering them appropriately is a problem.
So we've been talking a lot about infectious agents, but absent these horrible spikes, in morbidity and mortality from infectious agents, the number one, sadly, killers in the world are diseases that are what we used to think of as first world diseases, things like cancer, growingly metabolic diseases. And we have with us Surbhi, who has spent her whole life thinking about this. She's, as I mentioned, a radiation oncologist. But by the way, and I'm a PhD, not an MD, the divide that occurs between radiation oncology and medical oncology is probably a phenomenon lost on most of us. And I would simply say that what Surbhi brings to the table, because she's worked in many global settings, is the ability to marry these areas. Because when you suffer from, you get diagnosed with cancer, you just want to find a cure. And the reality is the cures are a combination of a lot of different treatments, sadly, as many as us know, either from our own experiences or our families. But Surbhi, maybe you could, she's been spending a lot of time in Botswana, for example, but also does some work in India. So Surbhi, what are the main challenges in, I'm going to broadly phrase them on non-communicable diseases, but you can focus on cancer with regard to appropriate levels of care in lower middle income countries. And then maybe you can morph that into your work in India and what you've witnessed and seen there.
Yeah, thanks, Glenn. I mean, I think you've highlighted a lot of the issues. There's a lot of connections between what you talked about and cancer. I mean, we're starting to realize much more the connection between the gut and cancer. So actually, one of my interest areas is looking at HPV therapeutics for treatment of cancer and how to use that further in cervical cancer. But Glenn, to your point, there's several challenges in cancer care delivery. One is the multidisciplinary nature of it, right? So you need all the pieces, not just the radiation oncologist or the medical oncologist. You need the pathologist and the radiologist and everybody to be working with utmost quality to make sure that's happening. You need the appropriate care navigation and the care coordination and the patients with some awareness and education to actually have the center to go to where someone knows and diagnose them and triage them appropriately. So the challenge is I work in Africa mostly, but a bit in India, and I grew up in India, so I understand some of the systems. There's some challenges that are similar, right? I think some of the challenges in rural India are quite similar to the challenges in Africa, but there's some that are very different. I think in Africa, there's a lot of issues of actually just expertise and having access to drugs, which is very different in India, and I completely agree. There's actually plenty of drugs. Giving them appropriately when it's right and in the right dosage, that's what is the biggest challenge. There's a lot of expertise in India, but actually getting to the right expertise is a challenge. The other big challenge, both in Africa and India, is the cost, right? So it's really great to see what the next initiative coming with the universal health coverage. I mean, that's in India, most of cancer care is out of pocket. And then the centers that can provide that quality care are very limited. So Tata is a world leader in cancer care delivery, right? But it's one center, and they treat about 35,000 cancer cases a year, and it doesn't even scratch the surface, right? You see lines and lines of people at the large centers at AIIMS and public centers like AIIMS and PGI, and it doesn't even scratch the surface. As a result, there's a lot of private centers that have come up, but again, the cost is really high. And from what I understand, just again, back to what is the treatment being prescribed? Is that the right treatment? What are the, how are we accounting for actually following an evidence-based guideline protocol? So that's a big challenge. And I think there's a lot of initiatives underway. So for example, Tata has really taken the lead on this. And they're really setting up a large hub and spokes model where the main center is out of Mumbai, and several new centers are being set up. There's one in Varanasi that's running now, one in Vizag, one in Mullanpur in the north, which is quite novel. And I think there's a lot for us to learn from India in Africa to do that as well, and really setting up those centers of excellence. Yeah.
How much of the, and at least from what I've seen, and I'm sure you'll agree, I mean, one of the main challenges in many of these settings is the late diagnosis of disease. And so how do you think about, when you're designing your programs, about improving, what are the main barriers to like the late diagnoses? People are coming in, stage 3 and 4
Right.
cancer, as opposed to what might happen here. Look at the changes in breast cancer, survival rates in the US, for example, which are mostly due to early diagnosis.
Yes,
right? So,
absolutely.
So how do you get to that? Because that's not vaccines, that's not drugs, that's societal awareness.
So actually my journey in radiation oncology really started in India because, and through the community health workers. So I was working with the ASHA workers in India during my year off in medical school with the National Rural Health Mission at that time. And through that, because of the work with the ASHA workers, it was actually maternal mortality related work, I ended up at Tata, met a radiation oncologist, and hence I'm here today. But I think that actually has given me a lot of ideas, and I'll tell you how this connects back to Africa as well. But this community health worker, she's responsible for the community, just for the prenatal care, but has been equipped with at least the basic knowledge to make sure a pregnant mother is getting what she needs, as well as recognizing the high-risk signs and getting them to the right care. And there's trust in the community for this health worker, which makes it a lot easier as opposed to any one of us going, or any physician going in. And same, there could be a lot of miseducation, and there's a lot of people like traditional healers in Africa. I mean, something similar, there's a lot of that in India as well, where patients are not referred to the right place. So there's a lot to be learned from the role of those community health workers that have the trust, and I think, which is what we've leveraged for HIV in Africa, right? To get away from the traditional healer, so there is a person who has the knowledge and knows the pathways for triage in the community. And that's what we're working on in Botswana exactly, to get patients early as quickly as possible.
Yeah, great. Well, we've been dominating this conversation, so maybe it's the right time, yes, you think? I'll open this up now that you all know who I'm going to vote for in the fall, in another month. I've been clear about that, I think, a couple times. So questions from the audience for any of our panel members? Yeah? Please use the microphones. If you just briefly state your name and then your question, and who you want. Well, if you have a preference for who should answer, state it, otherwise we'll figure it out. Yeah.
I'm Nitin Gurgay. I'm one of the MD PhD trainees here. I'm thinking about lessons that our institution could learn from the vaccine development in India. And I'm wondering what the relationship between the Indian Ministry of Health is and these vaccine development centers. So is it that the Indian Ministry of Health is doing things countries that like incentivize vaccine development and locally, or is it more like the ground up from these kind of centers? So I'm really thinking about if, for example, our university has intellectual property for COVID vaccine, what are ways that we could share it or promote other types of open use?
So for both of the rotavirus vaccines that got to licensure in India, the Department of Biotechnology was a key player. One, the secretary had developed the vaccine initially, but also supported the second vaccine moving forward. And for COVID-19, other than Serum Institute of India, every other company that developed a COVID vaccine had support from the government of India for some stage of the vaccine development. So in general, the government is very supportive of companies developing vaccines. The scale of the funding, according to companies, is never adequate. So, which is why they need to get other sources of funding in as well. Some of these, the Gates Foundation has helped, but there has been, the US government has an investment bank that also helped with one of the COVID-19 vaccines. So multiple sources of funding.
Yeah, generally speaking, and you guys will correct me if I'm wrong, there's not a great business model surrounding vaccines other than the major outbreaks when they occur. And so it's been one of the challenges, I think, historically of keeping the, particularly the large, pharmaceutical companies in the vaccine market for making. So I think this is an example where government, I think, needs to play an important role. And I think the more that, and this is something I know that, so unfortunately, Drew Weissman, who, and he and Katie developed the mRNA vaccine platform technologies. One of the things that Drew is working on is how to create clusters of centers around the world that can work on multiple vaccines simultaneously, because there's enough percolate. How many viruses are there out there, Sarah?
People say there's 350 viruses that infect humans.
Yeah.
That cause disease in humans.
Yeah, but how many total viruses are there?
Thousands.
Yeah.
We don't even know.
And we discover more, exactly, because we're discovering more all the time. So we don't know what's coming next. And I think the way to, in many ways, to deal with these problems is to be prepared by accelerating the pipeline so that the vaccines can be prepared quickly and get to the right parts of the world as fast as possible. Unfortunately, not in the way COVID originally happened, which was, all the vaccines, frankly, being bought up by, the UK, the United States, and a few other countries. So fortunately, India was, on the ball from some of their previous work. Other questions? Yeah, over here.
Hi, my name is Anya Luma. I am not anything to do with medicine, but I work on gender issues, including gender in India. So my question is this, that with ASHA, which you mentioned, that was a Rajasthan government initiative, and many of the community efforts that you, Dr. Ronak, described seem to be coming, it's not clear to me how much are they individual efforts from hospitals like Christian Medical College or large scale. Right now, what would you say is the situation of the government, helping develop these, because, they rolled back things like Renega and so on. But with this and with medicine, is there still funding and imagination to implement this large scale at a local level? Or is this largely now in the hands of, NGOs or other organizations?
Well, health is a subject that is on the concurrent list. So policy at the center, implementation by states. So if you look at the parameters of how health should be measured in a population or how medical services should be measured at population level, you can see that there is a difference across states in India. And it's very much dependent on how much states invest in health. So for example, every PHC in Tamil Nadu has an ultrasound machine, which is very important for pregnant women. That is not the case in Haryana. And it isn't that the policy doesn't exist, it is how does the state implement the policy. And some states like NGOs to help, but I think ultimately this is the responsibility of the state. Primary care should be provided by state providers, and they have to figure out the mechanisms by which they're going to do that. There have been suggestions that this could be something that could be contracted out. In general, contracting of government services doesn't work very well over long scales of time.
Question over here. Yep.
Hi, my name is Alex Casana. I'm a professor of economics at Wharton. So earlier in your talk, you referenced this mismatch between where the researchers come from and where the research is done versus where the beneficiaries are and where the disease burden is. And towards the end, it's super exciting to see that India is becoming a global leader in vaccine production and distribution. But this seems to have at odds with the first goal where you want potentially other countries in the world, for example, in Sub-Saharan Africa, Southeast Asia, to be actually investing more in developing their own pharmaceutical development infrastructure and relying on India. What is your policy position on this?
So I don't have policies of my own, but conceptually I can tell you that where India is the result of significant investment in science education and in technology than has been seen in many other countries that started from the same point. Have we done everything we could with it? No, we haven't. But we are in a way better position to make products than many other countries are. So now if I think about Africa making vaccines, now everybody's talking about local manufacturing of vaccines, but Glenn brought up the point that in the West, vaccine companies don't want to make vaccines anymore because the financial model doesn't work. That's with the $200 vaccines, it doesn't work. In India, same vaccine, $3 and we still make a profit, right? So you have to think about what does it take to have that infrastructure. And I've spoken with some of the Indian vaccine companies, why don't you go set up shop in Africa? And they're like, where's the manpower? Where are the people that we can bring in to be able to make these vaccines in another location? So if you can't service the machines, if you don't have that kind of infrastructure in terms of supplies, but more important, people, they say it can't be done yet. So what we need to do is to make sure that we raise standards of technical education first, and then figure out how they stay where they are. Because the other problem that we have in Africa today is what happened in India, a brain drain. Everybody who had an opportunity somewhere else left. So now, for example, we train people in bioinformatics in Africa. As soon as they get really good, someone in the Netherlands is going to hire them.
Yeah, Surabhi, maybe you could touch, you've witnessed this firsthand working in Botswana, just north of South Africa, and the brain drain that just occurs from one border country to another, right?
Yeah, and look, I think there's there needs to be continued South-South collaboration, right, in terms of for education, capacity building, and teaching. And honestly, when we think about oncology and we think about, okay, we need a training site for image-guided brachytherapy, it's, I don't want to actually put my energy and resources in finding a site in the US because it's completely different context and not that helpful, right? What we think about is, okay, which site in India can we work with to send a team there for training? Because that's actually just much more useful. So I think right now in most parts of Africa, and Africa is a big continent, there's different countries with different issues. I think we're still trying to figure out some of the, in oncology at least, just making sure the basics are there, right? Half of the continent doesn't actually have access to radiotherapy for, again, some of the issues Dr. Kung just brought up, like maintenance is a huge problem, service contracts, parts, all of that. So half the countries don't have access to radiotherapy. And so how do we actually solve some of those system problems before we can get into more of the manufacturing? And it needs to continue to happen. The education needs to continue to happen. But we're not there yet where we can say, okay, let's stop. We're going to actually build the linear accelerator here. I think right now we need to just figure out how to get a machine, keep it functioning there, treat patients with quality, and then we'll start to think about, okay, is there a better machine for the context here that makes sense to be manufactured here?
Yeah, I mean, when we first created the Center of Global Health, one of the things we did it was conduct, well, we do this pretty much annually, but a survey of what people are doing and where, and maybe it won't surprise you, that almost 70% of what we do in our School of Medicine, the global work by our faculty, is what we would call developing the professional attributes of our colleagues in country, finding the right partners and helping to develop those individuals. So it's not coming in and just conducting care or doing research. It's actually developing the talent pool. So that, without question, is just as Jerry and Surbhi were saying, is the biggest challenge to what you're describing. Because you can talk about building institutes in different parts of the world, but if you don't have the talent, and talent broadly, not just the people doing the sciencey part, but all of the surrounding areas around it to keep the effort going, it just falls apart. People leave and it just dissolves. Yeah, next question. Yeah, right here. Yeah.
Excellent talk. Later, what a lifetime of accomplishment and quite a family. My question is that given the proximity to disease and the sheer numbers in places like China and identification of viruses and development of vaccines and production, why is that not part of the global infrastructure for this whole process of identification?
So in terms of where viruses emerge from and what we can do to mitigate against them, there is an exercise called the Coalition for Epidemic Preparedness Innovations, and there is work that the NIH is doing, which is called the Priority Pathogens List. So I think Sarah spoke to 350 viruses that infect humans. They belong to about 25 families that have the potential to cause large-scale outbreaks. And the idea is, if you can make a virus for one member of the family, can you quickly, make a vaccine for a virus that is one member of that family? Can you quickly adapt vaccines to another member if it emerges? So an example for SARS-CoV-2 is the fact that there were already vaccines for MERS that were being made, and the same principles got adapted for SARS, right? So if we come up with 25 different vaccines and we have them ready, then it should be a small shift, hopefully, to make vaccines for whichever new virus emerges. And the idea is that you should have global partners to be able to do it. The NIH obviously is interested in defense for the US, but CEPI is an organization that functions for the world. It's also donor funded. So hopefully we will do better. I think we did a little bit better for SARS-CoV-2 than we did during swine flu, which was a little bit better than SARS. So now the question is, next large-scale pandemic, how will we do? Mpox is showing us not great at the moment. So we still have lots of lessons to learn.
We have time for 2 more questions. We'll go way over here in the front row in the purple sweatshirt. Is that purple? Yeah. Is that, what school is that?
Maroon.
Maroon, sorry.
Thanks so much for your talk. My name is Eric. I'm an undergraduate here at Penn. And I have a question for both Dr. we finance and how can we develop the resources that are necessary to treat more complex conditions in a similarly sustainable way? Because I think that's a whole different set of challenges than diseases that can be treated by vaccines.
So Surabhi, you want to go first for
Sure.
cancer, and I'll do complicated cases.
So I think the long-term game is that we need to focus on how to get patients in early, right? At the end, it's early diagnosis, catching cancers at early stage, being able to cure. That's absolutely key, right? All your fancy drugs and tools only come in handy at the advanced stage, and then even then, the outcomes are poor, right? So to me, preventing cancer and then early detection is absolutely the key. And so for prevention is, again, screening, and screening, not just screening, but really screening with appropriate follow-up and triage, because we can't forget that. That's been a huge challenge with, I hope it's okay to say, with some of the PEPFAR funding, because there's been a lot of funding in cervical cancer screening. But then if the patients are not followed up, patients with the CIN2 and 3 are not followed up, these patients will show up in my clinic with advanced cancers. And then the other issue is early detection, and we got into it a little bit already. Challenge with early detection is education, right? And who do patients trust to first go to, right? And is that first person really gonna say, okay, these signs are concerning, we need to send you, to the right clinic to get evaluated and worked up? Or this person is just gonna give me a bunch of herbs, a bunch of antibiotics, which happens a lot in the patients I see, and then the cycle continues, and the patient goes to another person. No one actually refers the patient to the right clinic to get evaluated, worked up, et cetera. So to me, these are the two, but these are both system issues, right? We know what to do, but implementing and setting up a system that works, that's the bigger challenge, and resourcing into that, I think, is key. Yeah. The rest, I think we have done enough work to know how to treat most of the cancers, right? At least at early stage. And we have a pretty good model of how many machines we need to buy, how many drugs we need to source, where we need to get them from. That part, I think, is not as complicated, but these first two, I think, are much bigger fish. Yeah.
Okay, now can I be really pessimistic? I don't think anyone does complicated cases well anywhere in the world. So we've gotten into systems of medicine that are very, very specialized. A cancer specialist is a cancer specialist, is not a cardiologist and is not a nephrologist. What happens if you have problems that are kidney, heart, and cancer together? How do you manage a patient with multimorbidity? And throw diabetes in for good luck, right? It's very difficult. And I think there are very few places in the world where you can treat patients with multiple diseases really well. So early detection obviously does matter because you catch diseases early at a stage where they can be handled. Once it gets into a really late stage, it becomes hard to handle that primary disease, but handle everything else as well.
Okay, one more. Sorry, there'll be an opportunity for the rest of you to ask questions of the panel in the reception afterwards. So.
Great panel, thank you. I guess I have a public policy question, and I want to go back to an old adage that prevention is better than cure. There is a huge amount of resources dedicated to treating, curing, screening, but it feels like to me that society and maybe academics, the medical profession, governments all have a role to play. We don't do enough in understanding the two pathways to disease and changing behavior to prevent singular, maybe not singular, but a rare example is smoking. And so once we understood lung cancer is caused by smoking, you can see with a 20-year lag, strong correlation. I wonder, more can be and should be done, and what will it take to do to understand pathways to disease and stop, them before they even begin.
Yeah, I think, you've hit on a fundamental problem in public health. One is, how do you measure health? And in preparation for this lecture, I was thinking about Rome, which was this big thing that I came in about reorienting medical education. But the other big thing at the same time when I joined medical college was all this excitement about the Alma Ata Declaration, Health for All by 2000 AD. And if you read that declaration of Alma Ata, it actually says, health is not the mere absence of infirmity. So how do you define health and how do you maintain health? I think, we failed for Alma Ata. We'll fail the Sustainable Development Goals. But I think this focus on making sure that we understand what prevents disease and how to make sure that people are educated to follow good behaviors in early life really matters. You know already that people who have a better education are thinner than people who have a poor education. How did that happen? What is it that we need to do to think about those kinds of reinforcements of good behavior and starting and maintaining them as much as possible?
But you're correct. We don't emphasize enough that in our society, in our medicine. I mean, it's interesting. I mean, I'm probably the worst person to be talking about it. I'm a radiation oncologist, specialist of a specialist, and I'm already talking about prevention and screening, and now I'm going to be talking about functional medicine. But I completely agree with you. I think there's really not an incentive. That's the issue, right? Because we live in a society, and I think this is a system that we're also sending to the rest of the world, or fee for service. And unless you do something, you don't get paid. And that's a problem. Even in our medical school education, right? Functional medicine wasn't really a topic. Was nutrition even a topic? No. So that's, I think, also something that needs to be altered and changed, right? Because we do need to go back to the basics and maintain sort of this, level of healthy living before we start talking about everything else. Yeah.
Okay, so I want to thank our panelists, Cherry, Surbhi, and Sarah. Thanks to all of you. Do you want to come up and say something at the end?
I just want to say, please eat and drink with water.
Yeah. So this ends the formal, the sort of the formal part of this afternoon and this evening, but please stay, and we have lots to talk about. So thanks again.